I mean, you all know what is stroke. Stroke, paralysis, laqua. So any kind of bodily change, suddenly, be it change in speech, your power, your sensations, your bladder bowel control, your vision, any change in any bodily function which is sudden in onset could be impending stroke. WHO says fast facial deviation, arm weakness or leg weakness. S stands for speech change and T stands for timely intervention. So timely intervention is very important in any stroke patient, because in last decade or so there has been 3-4 major advancement in stroke management. You all know if somebody has a stroke, if you know fast, you identify 90% of stroke patients. So once you diagnose them in time, you tend to send them to a place where a blood sugar and a CT can be done. Simple, these two tools, and you can give a IV thrombolysis. So we have two things, TP and this tenecteplase nowadays. So it has to be given within first 4.5 hours. So this is time window period for IV thrombolysis. And most of you who are doing myocardial infarction, indication are within first 4.5 hours. There is no hemorrhage on a plain CT scan, because plain CT scan in first 24 hours will not show you anything. I think we have a CT scanner here also, right sir? So this can be done as early as possible. So IV thrombolysis is not supposedly to be given by a neurologist or a physician. Whosoever is the emergency doctor, he should and he can administer this. So this is what about, so there is standard protocol. You just need to have couple of or maybe a 7 days training to administer IV thrombolysis. Any MBBS doctor can do that. So once you have this NIH stroke scale training, so anybody whosoever wants, they can come to, let's say, my center also, and they can stay there for a week and learn this and do it on their own with this certification course of 7 days. So that's not a rocket science here. Second thing is, once stroke, primarily we all know stroke could be either a large vessel occlusion in your carotid artery or middle cerebral artery. It could be from your heart, that's cardioembolic, second subset. Third is small vessel disease or vasculitis or some hypercoagulable state. And fourth category is all miscellaneous rest of the causes, whether it's some hypercoagulable state or some kind of genetic problem. So primarily these are 4 types of strokes. So for a large vessel occlusion, let's say somebody has a left-sided hemiplegia with right middle cerebral artery occlusion. So this left-sided hemiplegia, because of right middle cerebral artery occlusion, is not going to open up with your antiplatelet, with your statins, with your other drugs, or even with IV thrombolysis. Only 10% people will recanalize with that. And somebody who has a large vessel occlusion in the brain, they would have a big infarct. So person would be handicapped. Even if he survives, he will be handicapped for lifelong. A large infarct would happen. So in that case, dictum or standard of care is you reach to a center where there is capability to remove this thrombus by a procedure called mechanical thrombectomy. So that window period is up till 24 hours. Nowadays, I tell you that this can be extended in certain situations, but usually it is 24 hours as of now with present literature evidences. So first 24 hours, somebody had a large vessel occlusion, you reach to a center where they take you in the cath lab, rule out a hemorrhage, see on an angiogram. It takes 10 minutes to open up the vessel. I mean, it's technically probably the easiest procedure. As sir, you were saying, thrombectomy, sunte bahut ho gaya. So this is thrombectomy. This is plain thrombectomy, which takes around 10 minutes in a cath lab. In Pacific, we have a biplane cath lab, which is one of the best cath lab. So the procedure time is very less. If there is a occlusion, more than 95% time you end up opening the vessel. So that's a simple procedure. Obviously, third thing is treating a stroke patient in a place called stroke unit. Instead of putting them into an ICU or in a ward or a suite room, put them in a stroke unit where simple things can be taken care of, like how much blood pressure you want to control. So, like many times people ask me, what should the target blood pressure in a stroke patient? Okay. So suppose somebody has a large vessel occlusion. So don't play with the pressure. If it is 200, let it be. If it is 180, let it be like this only. Just reduce 10% every day. Don't, because there is already vessel is blocked. You have not done IV thrombolysis, and even if you have done IV thrombolysis, in that case you have to reduce the pressure below 180. because otherwise patient will have reperfusion and hemorrhage. So if you have not done IV thrombolysis, then let the pressure be as the nature has made, because nature is raising the pressure to perfuse your brain. So let it be like this, unless until somebody has a congestive heart failure or aortic dissection, something which necessitates quick lowering of the pressure. And don't lower them drastically by giving sublingual nifedipine or things like that. Just 10% every day is a dictum. If it is a vein hemorrhage, ICH, lower it below 160 Mbps. So that's because in ICH you need more lowering of pressure compared to a ischemic stroke. I mean, since ischemic stroke means because of any occlusion in your vessel, you have ischemia and infarction in brain. Hemorrhage is opposite to that. Hemorrhage, most of the time, it is hypertension which is responsible for hemorrhage. But sometimes if patient is not hypertensive, especially patient is young, less than 50 years of age, then this could be aneurysm, AVM, which is blood. So these are structural causes of hemorrhage, where you should do an angiogram. Again, DSA, same thing which you do in ischemic stroke also. You do a DSA, pick up an aneurysm, put coils, or if there is AVM, put some glue into that and occlude it so that patient doesn't have another bout of hemorrhage. So what I was telling, stroke unit is a very important thing to just measure and keep the pressures in the desired range. Give them adequate fluid, nutrition, because these are important things which affect your outcome at 3 months or 1 month or a discharge. Small things. Take good care, good physiotherapy right from the day one. Whether it's speech therapy, swallowing, because patient will aspirate. If you don't teach them a good speech and physiotherapy, they will aspirate. So the rehab, which is very important, that should start from the day one itself. So that's again, you should have a good rehab team like